Hola, buenos días a todos los que estáis al otro lado del Zoom. Querría daros la bienvenida a esta conferencia final.
Final conference, and I would also like to introduce you to who is going to be our speaker. She is Margaret Harrison, and we have worked with them as collaborative centers of the Joanna Briggs Institute for quite a long time. Dr. Harrison has devoted her entire professional career to research based on evidence in order to improve clinical practice. And in the year 2004, she developed and was the director of the Queen's Collaborative Center in Canada. And this center in Canada was, in fact, the first North American center of the Joanna Briggs Institute. Margaret has always worked focusing on clinical practice to develop techniques and tools to enable the implementation of evidence in clinical practice. And because of all this work, I believe, I can't remember the year exactly, but in any case, she was awarded the Passaim Award of the Queen for research. She has published 137 articles in journals with top peer assessment, and she's the first author of an application that I think is indeed very, very useful, really, and it can implement, which is the planning of implementation and the knowledge in clinical practice, adapted, of course, to the context of where clinical practice is being implemented and deployed. She's also recently written, and I'm sure she'll tell you about it too in her presentation. She's the author of a book, and it means it's translation of knowledge to clinical practice, a roadmap for healthcare based on evidence. As an emeritus professor, Margaret still works as a volunteer with different partners of the community. The first part of the conference, of Margaret's conference, was recorded previously, and as soon as this recorded part of the conference is over, well, you can see her, she's there with us, so she'll be here for any questions or remarks or any discussion you would like to have. So now I give the floor to the recorded part of her conference.
Warm hello from Canada. I only wish we could all be together for this, but thank goodness we have Zoom. Earlier, I was speaking to Esther about not having a haircut, as we've been in lockdown for months, and possibly only having it on audio. But she didn't agree, and so I had to do something with the hair. We've been sharing these kinds of Zoom funnies for a while here, and I'm sure you have too. Just one more before we start on the light side here. When your anatomy class is now on quarantine, and look at them all having their anatomy class. Anyway, more seriously now, this is one of my favorite quotes. Knowledge is of no value unless you put it into practice. This is from Anton Chekhov. And I have followed this creed for quite a while in my own work. So the aim today is to explore the key role of synthesis in contributing to successful implementation. We're going to walk the journey from synthesis to best practice implementation, but I'm going to start with a confession. In my clinical life, working with the quality portfolio and nursing practice issues, I was yanked into synthesis. It was how I got out of a very difficult situation in the early 90s. Yes, I know, eons ago, but still, it's a good message. At the Children's Hospital where I worked, the chief nurse tasked me to sort out a problem with children who had central lines for treatment and nutrition. Difficulties were occurring across the various clinics and inpatient areas. And when transitioning to hospital, out of hospital to home and school care, it was a very serious issue, and there were many opinions about what the problem was, whose problem it was, and how to fix it. Nurses, nutritionists, home care, and of course the children and their families themselves. In our early meetings, we were going in circles, Then I had a major aha moment. Let's look at what is known. We will go to the external research and literature. It was life-changing. And what it did was have the effect of removing the stakeholders from their entrenched positions to work together, looking outside of our organization and their own practices. Now remember, this is the early 90s, so we aren't talking about a JBI style rigorous review, certainly not systematic as we do now. Nonetheless, gathering the evidence was a key factor in getting everyone to pause with their own opinions and experience while we looked at the external literature and research. And as I moved my research career in activating evidence in practice settings, I have never forgotten that lesson. I hope to share that experience of how synthesis and knowledge creation itself are absolutely integral to successful implementation of evidence-informed practice. Now, from the Children's Hospital experience a long time ago, we went on to gather evidence locally about the context to plan for implementation of best practices with central lines. It also eventually led me to start the first North American JBI Center at Queen's University, Canada. This leads me to the main message today. Synthesis is not only a part of evidence-informed practice, it is vital in assisting successful implementation. It's not only about the completion of a systematic review and compiling the evidence in a rigorous manner as a starting point, but it's also about strategic alliance and partnership formation, targeting the right mix of researchers and academics with the practitioners, as well as with individuals and families. My work has largely been in the field implementing best practices, but I can tell you that the foundation, without any doubt, for successful implementation is set during the synthesis phase. Why? Let's explore that a bit more. Many of you are familiar with this Canadian framework, the Knowledge to Action framework that was developed by Dr. Ian Graham. He's a Canadian health sociologist. But what you might not know about this is that it's the first action framework to include knowledge creation component as part of implementation. KTA was initially created from the review of 36 planned action theories and frameworks. And currently in 2021, it's undergoing an update, so stay tuned. You can see the knowledge creation in the center leads to those 7 action steps where we engage in active, on-the-ground implementation of evidence-informed practice. Looking at the knowledge funnel, though, specifically, you can see that we go from the top, where it's called knowledge inquiry, and we're looking at primary studies that then go into a synthesis that then are used to develop knowledge tools and product. This is a process of distilling knowledge, so it's more and more useful for practice. It is difficult for a practitioner, if not impossible, to go to the literature, review and assess however many studies, dozens, on a particular topic, to come up with a solution to a practice issue. Ideally, the research has been amalgamated into a synthesis, and from there you can see the direct link from synthesis to practice through knowledge tools. Currently, our most commonly used product is practice guidelines, but sometimes we develop evidence-informed protocols simply from synthesis because there's not a guideline that actually fits. So you can see how synthesis, being part of the knowledge creation element, is absolutely essential to beginning the process of implementation. And if we believe implementation is a partnership with practice, which of course we do as JBI centers, you can see that it has to begin in that phase before entering those 7 action steps. Now, partnerships can be tricky. Partnerships and collaboration are built on trust. This begins when you are formulating those questions for synthesis. Why? Well, you have to have the right question with the right outcomes, so it will be most meaningful to those end users that you hope to uptake the evidence. We have found that building this trust from the get-go during synthesis is essential. Let me give you an example. One of our first JBI syntheses was focused on visiting hours during the SARS outbreak, mostly in Toronto here. Local agencies in our community wanted to base their changes and restrictions to visiting hours on what was known. Visitor restrictions had an important impact on pediatric and adult populations and their families. So before they moved to develop their restrictions, they asked us to do a review. And the review was not just a documentary analysis of existing policies. They wanted to have us look at the impact that would have on children and other patients in the hospital. So that's what we did. And the visiting hours policy was formulated following that review. And in this example, both the question as well as the outcomes were nominated for synthesis and driven by those end users. In another example about transition from hospital to home for individuals with heart failure, the question was different from different stakeholders. The hospital wanted to know about the emergency use and hospital readmissions after a discharge. The nurses and patients, however, wanted to know, with additional preparation, what effect that would have on function and quality of life. It was a fairly simple thing to incorporate all these different perspectives in the research synthesis at the planning stage. Interestingly, the majority of research did focus on resource use, that's ER visits and readmission. And the synthesis we did actually showed there was very little on function and quality of life, regardless of the interventions. So this synthesis actually led to conducting a trial on transition with function and quality of life as primary outcomes and the resource use as secondary one. That journey from synthesis is a whole story in and of itself for another day. Now, moving on, I'm going to switch gears a little here. The knowledge to action framework gives us a very, very broad view of, like an umbrella actually, over all the many aspects of implementation, from knowledge creation to implementation and sustainability. The question is, how does this broad view actually work in practice, in the field? We refer to this as when the rubber hits the road. In other words, the evidence is near the ground. It's been partly translated, but it's not quite there yet in terms of being used and being taken up. The substantive preparation work on synthesis that you've done now leads to creating, adapting, or using a quality guideline, our most common tool, but sometimes developing a practice protocol from the synthesis if there's not a guideline that fits. Any of these will be based on the synthesized evidence, though. However, that is not the end of the story with synthesis. There are many more opportunities in active implementation where synthesis can be called on again. Turning to implementation, activating knowledge, KTA provided that high-level guide. But what I'm going to speak about next is what we have learned from the experience on the ground of numerous implementation projects, mostly with guidelines and complex health populations like people with heart failure, chronic wounds, stroke, etc. And Simply put, knowledge activation is aligning that external best practice evidence with the context you're working with. So when synthesizing external evidence, the process of doing those systematic reviews, how can we influence implementation and uptake? Well, there's a number of ways, and that's what we're going to talk about next. Our experience with knowledge activation in the field has consistently been that implementation basically falls into three distinct but overlapping phases of focus. The work is organic, that is, building on the previous steps and processes, but sometimes we have to return to a previous one, so it's iterative. I'm going to highlight some points on each of these three phases. Phase one is the identification and clarification of the issue and problem. Phase two is solution building, and phase three is implementation, evaluation, and sustainability, something we often don't think enough about early enough. So looking at phase one, in a nutshell, it's understanding the issues from all sides. It's identifying those key stakeholders, knowing if the issue can be solved with an evidence implementation, or is it something else? Like sometimes we think that all we have to do is take a guideline and take it to the clinic and that's going to solve the problem. But sometimes it's a reorganization that's needed or something else. Clarifying if the issue is small and focused or widespread, and exploring the external evidence and understanding that gap with local practice. During this stage, there are some pertinent questions that we ask. And these are some of them, but they're not, these include but aren't limited to these. These are just some examples for you of what you would be thinking about at that stage. What is the issue? Who is concerned? The relevant population and providers. What is the extent or magnitude of the problem? And what is what does that external evidence suggest? Is your local population similar to the study populations in the literature? Now, in this stage, synthesis may be revisited in a number of ways to describe the prevalence and incidence in the literature. Could be quite important. Like, does your preliminary data show that you have a certain prevalence of, say, leg ulcers? But how does that compare with the literature and other areas? Is it the same? Is it higher? This could be very important to argue for the importance of doing something locally to improve those rates. We certainly found this in our work with the leg ulcer population, and it was extremely useful when presenting this to administration and a regional board, where we needed to have some additional resources for the education that nurses had to undertake to be more expert with their leg ulcer care. We also found that with the best practice intervention, which was, and it's still the same, it's compression bandaging, visits to check on the compression bandaging should be done twice a week. But what we found in our preliminary data was that nurses were visiting 1 to 2 times a day sometimes. So this was a costly and unhelpful addition to care, and certainly not following best practices. At this point in the process of implementation, though, you are clear on what best practices entail. You have determined that there is an evidence practice gap in your setting, and that the implementation of evidence would improve the situation. So we move on to phase 2, solution building. And in this phase, you're customizing the best practice recommendations to your context. You're figuring out the fit with the local context. You're exploring the determinants of uptake, those barriers and facilitating factors. And you're looking at additional best available evidence. Like, we often look at service models, for instance, to see how, if we have to reorganize a little, how that's going to work and what is already known. And also tailoring the implementation strategies to build a new modified approach and then field testing it. Now, some of the questions in this phase are considering the gap between the current and the best practices, how appropriate and acceptable the best practice recommendations are for delivery in this context, how we could organize or reorganize to deliver best practice care, what supporting factors or barriers are related to implementing that best practice, how can we tailor implementation strategies to these factors, and also what will indicate the new approach is in place. Those are some of the questions that we ask when we're in this stage. During solution building, you often find the need to return to synthesis yet again. The approaches others have used during implementation can be quite helpful. In the leg ulcer example presented earlier, we recognized there was a gap in the community nursing practice, and we needed to understand the ways that an educational intervention could help this. So in a synthesis, we went in directly to look only at education interventions, describe all the different ways that people had done that to improve nurses' wound care skills and education. And in the end, the new evidence we found resulted in us developing a program that had a theoretical component as well as a practical one in a vascular clinic, followed by mentorship in the field to build confidence. This descriptive synthesis of educational interventions was extremely valuable when requesting funding for nursing time to undertake that education. And we had the international evidence behind it to support that and make the argument. Another important area we often turn to is the health services models, as I mentioned. We often use it first to compare it to the existing delivery and see what's different, if there's anything there that might be easy to change or modify, or if we need to make a new service delivery model. We actually did that in the leg ulcer. We moved from a home-based model to a clinic-based model. But in another example, in the heart failure one, we developed a hybrid model of transition from what was shown to be effective in the literature. These were special outreach nurses, often nurse practitioners, who delivered support and education when people were leaving hospital and to return back home with the chronic heart failure condition. And in the research studies, that's mainly what it was. They put a new nurse in. Well, we couldn't do that. So this is why we developed the hybrid model and figured out how we could still deliver those support and educational interventions through using our primary hospital nurse and the receiving home care nurse. So again, it was helping us build the case for doing things differently, and it being supported, again, being evidence-informed from the literature. Now, in the last phase, phase 3, implementation, evaluation, and sustainability, this is where you go into the actual launch of the new way of delivering the care. It's called the go live. And what you're doing here is evaluating the process and the impact, considering if it has made a difference, knowing what indicators and processes could be embedded after your implementation is done in the quality improvement portfolio, and planning for the change to be sustained over time. Now, that's placed here in phase 3, but it's really something we should be thinking about all the way through. And it often comes up when people are going through a synthesis and saying, you know, we could use that as an indicator because we already gather data on that kind of outcome, such as a 3-month wound healing. So it starts to prompt those questions early, but here we have to actually make a plan for that change to be sustained. So again, there's some common questions that we're asking in that stage, what elements of the implementation worked or didn't work, what new indicators and process could we embed in quality monitoring, and not only how effective, but how efficient was the reorganization of care, because mostly we can't change things if it's going to cost more money. What effect has the reorganization for evidence-based care had on patient, provider, and system outcomes? And how will that change be sustained over time? And here again, we return to synthesis to decide on how to evaluate. Is it through a program evaluation, a non-experimental design like a pre-post, or an experimental design such as a randomized controlled trial? We have done all of those types of evaluations, depending on the context, after an implementation or during an implementation. But how others have conducted these evaluations, dealt with the real-world situations and difficulties in similar contexts, can be very, very helpful. So this is why we, yet again, go back to the synthesis role. We have come to think of synthesis as a major and significant factor facilitating implementation process. Dr. Elizabeth Doherty's research on facilitation skills and knowledge, theories, and approaches describes facilitation as a process, not simply a single person. Because when we started to do evidence implementation, we started out very heavily having an implementer, a facilitator, a nurse who was responsible as a knowledge broker. For most of us, this is not going to happen in terms of adding a new person to units where you want to implement best practices. It's a process, so says Liz. We heartily support this view as we have studied facilitating factors and seen clearly over time the role of synthesis in aiding us towards successful implementation. A key message is that we think of synthesis as a key message is that we need to think of synthesis as an ongoing part of implementation to be called on as needed, not only at the beginning when we synthesize that evidence for people and then hand it over to practice. Because in implementing, we have often many more questions requiring synthesis. So what we found with facilitating as a factor of synthesis is that it creates and is honed to the end user's needs. So they have more ownership of it. It's a purposeful selection of the question, interventions, and outcomes for synthesis because it may be what they're particularly interested in. And we've often found that we've had to change an outcome for instance because it is what the user wants to know. They don't necessarily want to know they have an improvement on a particular scale. They want to know if they have functional strength and can walk longer. And so the outcomes that are important to that end user have to be identified at the very beginning. We also believe that it helps with that close fit with the practice issues because you're starting out with that and looking at the research to date with that perspective in mind. And I think one of the most important things that happens is it initiates an engagement process that does lead to this ownership. And I think it can guide implementation on call. So in other words, when a group needs your additional help, you're there for that. It's just not a handover from the initial synthesis that's done. Now, how we do synthesis can be groundbreaking. Of course, it amalgamates the external evidence in a rigorous way. And that's what methodologically we've all been working on over these many years after joining the JBI. But It's much, much more. It starts that collaborative process where input from those stakeholders can be incorporated early. It assures the relevant stakeholders are at the table. It leads to an educative phase about the evidence. And what I mean by this is people, just because they're looking at the literature and they're understanding what best practices are, they are learning about that research without having a quote unquote education workshop for them. It just begins to be part of the process of implementation. It gets everyone on the same page so that we know. And this is particularly important when you're going, like I was, from hospital to home with heart failure cases, because what they might do in home care and what they might do in the hospital unit have to be aligned. It identifies additional areas of concern for synthesis, and it becomes the natural first step in forming this strategic alliance to get that evidence in place. All of this leads to successful implementation. This is what Michael Gibbon calls Mode 2 science, and I love this quote. It's guided me for a long time. Creating socially relevant knowledge, working with the field and not apart from it. It's been one of my mantras for sure. And Michael Gibbon certainly wasn't talking about healthcare. I think he was mostly talking about engineers and other sorts of things, but it fits for us. So implementation thinking. Now this is more on the implementation side, and some of what I think we've reflected on over the years and put in our book. It's an organic process. Being evidence informed is an iterative, not a linear journey. The key is an engaged scholarship approach. It's participatory, beginning with the evidence synthesis. It combines empirical and experiential knowledge, because the experience of those practitioners and how they deliver care is absolutely critical in helping with the fit of the external evidence and that local context. It begins with synthesis and revisits it throughout. And patients, families, practitioners, and managers, researchers, all bring important perspectives. I think we've come around full circle now from thinking that methodologically we remove that from practice and experts do that, and then it's their problem to get it up and running in their settings. But I think we've got a new view on that, and that they have to be part of this whole process from the beginning. And I will end with saying that all of this, in a great deal more detail, is included in our 2021 book, Ian Graham and myself, Knowledge Translation in Nursing and Healthcare. And I hope that you have enjoyed this presentation and learned a little bit more about how you can use that synthesis process for implementation. The end. Thank you.
Muchas gracias, Margaret.
Well, thank you very much indeed, Margaret. Thank you. I am pretty sure that yes, indeed, we have learned, and that all the participants have learned about the process of implementation. And do remember, all of you, that there is a moment in which you can actually write your questions in the question and answer section down here in the Zoom screen, and we will get these questions to Margaret. So if you have any, please write them down and we can ask Margaret so that we can start a lively discussion about what Margaret just presented. In my case, as always, I think that this has been very clarifying. It's been really so said in such direct terms. Yes, what is it that's going on? What do we face? And what do we have to do to make sure that we obtain results, that we get to the care that we provide to the population as the best possible outcomes? Okay, so I love it. Yes, I agree with you, Margaret. You have to take it all into practice, and it's always been part of my approach to my life, to my professional life, because I mean it's all very good, very well to do research and have loads of data, but if that doesn't get to an improvement of the population in health outcomes, then it's no good. Well, we wait for questions to come. I did want to ask you, Margaret, because I guess that you have lived the same uncertainty as everybody else with the pandemic, right? Sometimes one gets used to working in a way based on results and based on evidence, that when all of a sudden a pandemic such as COVID-19 all of a sudden kind of makes your world go upside down and changes the way you work, and it forces you to work with uncertainty all the time. Well, at least in my case, I mean, I had become so dependent on searching in the literature what was best for something, that with this COVID, I felt like an orphan. I couldn't really help in decision-making processes when a question arose, because you always base everything on what had been written. But of course, on COVID at the beginning, we had nothing had been written. So to start working on uncertainty, when you're already very used to working on the certainty of evidence, for me was very difficult. It's quite a change, in a cultural change that we've not got used to. I don't know whether in your case you had similar experiences, or did you have to help the governments and in the decision-making processes, and how could you solve all this uncertainty, the lack of data in COVID-19, in order to be able to implement them to clinical practice in the context of this pandemic?
¿Me has oído, Margaret?
Margaret, did you hear me?
Hello.
Margaret, ¿tú me has oído la pregunta?
Margaret, did you hear the question, or do you want me to repeat the question? Hello?
Okay.
Can you hear me? Can you hear me? Yes, I'm
Yes.
testing, Margaret. Can you get the English translation now?
I
Can
have.
you hear me?
I
Okay.
can hear you. Yes.
Lovely,
yes.
lovely, perfect. Okay,
Okay,
well, I'll translate the question.
To translate the question, and I repeat my question. What you prefer? Madeleine? Vale. I repeat my question. Okay. Margaret, te preguntaba.
Yes, Margaret, I was asking you whether once we have all got used to working or making decisions based on evidence or based on clinical practice, it's a way of working that's already part of the way we work in our environment. And all of a sudden, when something like the pandemic comes along, yeah, COVID-19, and all of a sudden you are forced to work in full uncertainty, I have to say that in my case, it's as though you're always working with crutches, and all of a sudden they take those crutches away from you. At least it's been our situation. We had to, help to make important decisions, but suddenly there was nothing to synthesize, really no data and no evidence for support. So I was wondering about your experience in Canada, and how could you work or solve this, and did you help? Have you established some kind of protocol or some way of working that would allow you to have quick, fast evidence for, or a good, quick data for decision making? Because truly in Spain we had a lack, really, especially at the beginning, for decision making. Yes, impossible to base it on anything. It was based on uncertainty and on doing things as best we could.
Yeah. I'm actually getting the translation, Nettie. It's coming through. Can you hear me?
Yes.
So, but can you hear me, Margaret? Could you answer? Yes, I'm translating you into Spanish. Don't worry. Yes.
That's okay. So, this is a particularly difficult time, and the challenge is that it's really a live experiment in that we're receiving the information as the weeks go by. And in terms of amalgamating it, it's kind of as it comes, and it's very difficult. Our methods with quick reviews were never meant for this quick. So it's a very, very challenging time. I have not seen anything in particular that our government or the people that do synthesis, like JBI centers, have really discovered in terms of managing this. I think after this is over, we need to do a very careful reflection on what we do with quote unquote live evidence.
Eso.
Indeed, yes. Yes, I fully agree. We do have to learn how to manage things as they come. And then as well, I think that at least now in Spain, what we are at least, well, I talk for my environment. Yeah, I mean, the government asks us, how do we change the models of care to adapt to the new situation? And frankly, I mean, I say any answer that we give you is going to be an intuitive answer, no more. But there's not sufficient evidence to be able to say exactly what the best model might be. We don't know what will work in the future. We know what worked in the past, and we can see a bit, but truly, we're going to have to do things differently. And that generation of fast evidence, I think, is, well, I don't know, it's something new, a new paradigm, and it adds a difficulty, doesn't it? It's an added difficulty right now, don't you think?
It certainly is. And I don't know about your country, but in ours, we had some experience with SARS, another highly infectious situation. It was largely in Ontario, in the province I live in, and largely focused in Toronto, of course, because that's where Big International Airport is. I think what we saw, though, to be honest, is that we were not using evidence that we had. We had terrible situations in our long-term care, our aged care, our nursing homes. I'm not sure what you call them, but we knew what infection control measures were needed, and that's all based on very strong evidence. And we did not see that was implemented. So we're talking about basic nursing care issues. It's kind of like, it goes back to Florence Nightingale almost in terms of the environment and protecting the environment, or protecting the individuals from the environment. And we did not have the proper use of protective equipment, of masking, of isolation, and that's all old evidence. What we saw through this pandemic was many areas where there was evidence, but it was not used. There was new evidence emerging, of course, because this was a new viral thing. But a lot of what you do, a lot of how you control, is not new research. What's new is the cases we saw and how transmissible it was, and the epidemiological data. But the whole business of what to do and how to break transmission was really old news, old evidence that we didn't carefully follow. And I suspect it was similar in most countries, not just here in Canada.
Salvo que en nuestro país.
Yes, except the fact that in Spain, for example, we did not really have a SARS epidemic. We didn't have that previous learning. For us, it was the very first learning. Yes, but yes, I agree. Listen, look, in the question and answer section, there's a question for you, Margaret, where they say that one important barrier is to find a mechanism to update evidence synthesis as the evidence is produced. and institutions in general don't have human resources with adequate training to do that for supporting clinicians, okay? So then, is there any suggestion as to what to do? How can we update as fast as possible the evidence that's happening?
Well, it's an excellent question. And I must say it's one we've struggled with for years because, like you, there is nothing specific in organizations to assist with this as evidence emerges. Our sense is that it has to become part and parcel of the quality portfolio in organizations. If, in fact, most organizations say they're evidence informed or they're research based or they follow best practices, etc., then there should be an area within the organization that has some dedication to that has some role with that. And I'm not sure how fast it's moving. It's not moving fast here in Canada, but that door is starting to be opened because accreditation bodies here are saying that we have to see the evidence that you are evidence-based. So they're looking for how organizations are doing that. And I think that will be what will make this happen. It has to be institutionally based, and there has to be some mechanism like accreditation for ensuring that it will happen.
Muchas gracias, Margaret.
Thank you, Margaret. There's yet another question, and it's from Geisa Santos Goiz Lopez, and she says, thank you very much for your contributions. And she asks as well, do you know about any educational strategies that could be most effective in influencing clinical practice settings in the context of knowledge transfer?
Again, another really good question, because in a major review, quite a few years ago now, we looked at all the interventions, particularly for nursing, because with nursing, you're dealing with the team and the organization, different from medicine and physicians, where you're just dealing with a single changing practice with a single practitioner. And what we found was the most common was education. So we went back to it and we did a very comprehensive review on all of the different types of education that had been used and tested. And I think, again, there's not a simple answer, which I'm sure you're probably quite aware, but it's a matter of fitting it with the problem at hand. So as I mentioned, we went into a very comprehensive education program with the nurses' wound care issue and educating, and ended up with both the theoretical and the practical component. But what we saw in the literature, and there is quite a bit, is that depending on the issue, they would do short educational sessions through the different shifts in a hospital, for instance. And they would keep updating in that way. There was other examples where people were sent off for a workshop, so they actually took them out of the workplace. This isn't always possible. We certainly have found that in our work because of the resource shortage and because of the having to pay for people to take educational courses in most cases, that it wasn't really something that was possible. So what we found was the ones where we could integrate it into the normal work life of either a clinic or the inpatient unit. And again, then it comes down to how complex the issue was in terms of the clinical aspects of it. My question back, though, is were you speaking about educating people about implementation or educating people to prepare them for implementation? Because it's kind of two different things. You've got to get the skill set up if it's not there, but then you may have to do more in terms of planning for the implementation, which I don't usually consider education. I usually consider that the planning phase where, in fact, we really do engage the players in the field. It's not a push down from the top, of course, and so it's only through working with the unit or clinic, whatever it is, to figure out what their normal processes are, so that if it's going to require some change with the best practice, how we can make that happen. I'm not sure I've answered your question, but let me know.
Vale, si no responde.
Yeah, well, if you don't answer, well, then the author of the question, I'm sure, will write again. And while you were answering, yes, Sivas Moradi says, do you think the results of qualitative studies can be synthesized like quantitative studies?
Oh, that's been a long-standing debate, hasn't it? Personally, I always find that, so I'm not going to speak about the methodology parts of it because there's lots of debates around that, and I'm sure you know that going to many of the JBI meetings. What I find is that the qualitative literature gives me a lot of in-depth information that comes from potential end users, whether it be the nurses or whether it be the patients and families. So in terms of looking at it, we are often going to the qualitative literature as we plan, for instance, a new best practice program to find out what maybe the acceptance or what barriers there might be with the patients and families. A good example of that was with, again, one of my big projects, which was the leg ulcer one in the community. We found that the patients themselves wanted to be able to do more self-care, but didn't have the confidence for it. Now, this came from qualitative literature. And so when we read that, we thought, okay, so our education has got to expand, not just with the nurses and the specialists who were putting the best practice in place, but talking to the individuals who are receiving this care and finding out what they didn't actually know about taking care of their wound.
Muchas gracias, Margaret.
Thank you, Margaret. There is yet, a last question coming from Leticia, and she asks, have you been able to include, or how did you include the patient's view in the implementation process on the examples that you explained to us? So how to include the patient's view? Could you tell us to get the patients involved?
Yeah, again, that's a really key aspect. And the way we've done it is in some different ways, actually. Sometimes at the beginning, when we're doing a synthesis, we'll have a patient representative on there. And it's always a bit difficult to involve them in a credible way, in a way that is not overwhelming them with all the method and everything that we use, but helping us frame the synthesis in terms of the question. And so we found that very often, very vocal people who have an issue with a wound or whatever it is will tell you what they don't like about their care and what they want to see happen. That helps us frame up a synthesis sometimes. And as I mentioned earlier in the talk, one of the ones was that they were more interested in their function and their quality life after transition from hospital. This was the heart failure group. they, if they've got to go back to the hospital, they've got to go back to the hospital. And of course, the trials that had been done had all been done on that basis. But they were interested in how to improve their function and quality of life and management of their condition. So when we went to the literature, we looked at those kinds of outcomes. And as I mentioned, secondarily looked at the resource use, emergency room visits, and readmissions. When we, excuse me, actually got into planning the best practices, they said, well, how can we learn more? And the intervention about transition was one where was some self-education in it. They wanted it to not just be in the hospital, because when they were in the hospital, they were stressed. They were getting ready to go home. They couldn't concentrate. They wanted the nurses in home care to pick up the education. So we had to design the intervention so that it could travel with them from the hospital to the home and be picked up by the nurses that were delivering the home care. And the nurse had to know how far the hospital nurse had gotten. So, that information had to be passed in a really efficient way. So we sent the information and the booklet home with the patient, and the family. And we found that there was a much, much better uptake on it. We had reduced emergency room use and reduced hospital readmission after this. So you can actually, through listening to what is important to them, design things in a way more effective way. And we have seen that in a number of instances.
Muchas gracias.
Well, thank you very much, really, Margaret. It's been fantastic. Your vision has been great. Don't have more questions, and we're running out of time anyway. So before we say goodbye, Margaret, well, I couldn't stop seeing a photograph that you have wearing a hat at the back. Was that your nurse uniform when you were a young nurse? But I loved it. I really liked it, the photograph.
Oh, it looks like a Dixie cup. I don't know if you have a Dixie cup, like a medicine cup, right? And when I graduated, they had stopped wearing hats in practice because we were wearing hats, but they stopped wearing hats in practice, but our graduating class wanted to wear our caps. So they took our pictures with the caps. Oh, that's funny that you saw that, Nancy.
Muchas gracias.
Oh, thank you very much, Margaret. Really, thank you. Well, I hope indeed that we'll be able to continue to collaborate. We will have to talk about how we can get the book that you've written with Ian in Spanish. I mean, I think it's a brilliant opportunity. We've got to try and translate it for sure, to have it so that we can use it in Spanish, because, I mean, well, we have loads of Spaniards and all the Latin American community, of course. So we'll contact you definitely to see how we can go about this. And listen, that's all. I hope to hug you physically in real life soon, and to have a bit of touching each other. Yes, I mean, we need it. We need it. There's less time to go now.
For sure.
Thank you so much. Thank you. Thank you very much. Thank you all. Remember, you're going to be getting the assessment form. As this is a European project, it's very important for us that you assess the conference. You'll get different assessment forms with a link. So please do, because we need that. It would be very useful for us that you did that. So thank you, and thank you, Margaret, again. And listen, well, we'll keep in touch. Okay, bye-bye. See you. Goodbye.